Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Tony Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. Okay, well, thank you guys for joining us today here at PEM Chat. Today we are going to be talking about child sexual abuse and also sexual assault. So before we get started here, a little trigger warning that's going to be what our topic is today, just so you guys know. But I will say it with pause, because if you're taking care of children, this is a topic that you need to know about. This is something that you're going to encounter in patient care. And there's a lot to know here, a lot of information. And I am joined today by a friend and colleague, Jen Stanfield, who's been advocating for children for years and years and years. She has lots of experience in this area, and many, many pearls to offer us today. So thank you, Jen, for joining us today.
Thank you for having me.
Tell us a little bit about you.
I moved to the Chattanooga in 2003 and started working in the pediatric emergency department the same year. I have raised two kids who are now in their 20s, almost to be college grads. And I came to be interested in child abuse for lack of hospital resources to provide care for these children. It wasn't my intention to do this, but it is very difficult to look a child in the face and not be able to help them. And so that is where my interest was born.
And you are a PA?
I am a PA.
Yeah. And you've been with us for a long time. How long have you been working with us at Children's?
21 years.
Awesome. Thank you for being here. I really appreciate you. So how common is sexual abuse?
Well, I utilize the source darkness to light when I give you these staggering statistics that a girl's risk of being a sexual abuse victim between birth and 18 years is 1 in 4. And a boy's is 1 in 6. I think the boy's risk is a lot more surprising for people. I think that statistic has been validated by cases like the Jerry Sandusky case, the Penn State football coach who abused many boys during his tenure at Penn State. The Catholic Church has also been instigated in many, many cases of child sex abuse. And people are now realizing that it also happens to boys. In our department, we see a little over 100 victims a year. I think it's important to know that in child sex abuse, more than 90% are abused by someone they know. So this is not the stranger danger you learn about in early childhood education. These victims are being preyed upon by people that families know and trust. 40% of these victims are abused by older children. Why is that? Because for some reason, when a child is victimized, one of the first things they do is go and try that behavior out on another younger, more vulnerable child. And so that is a clear pattern.
How does this happen? That seems like an incredible number of children.
Yes, it's staggering. First, I think that number is very staggering. We should establish that the definition of child sex abuse incorporates touching, fondling, viewing pornography, being photographed, in-person sex acts, even watching in-person sex acts, coercion. It isn't always rape, but that certainly does occur. And so if you are 1 in 4 or 1 in 6, you might have viewed pornography, you might have been fondled, you might have been kissed, but no one ever penetrated you. It still counts as child sex abuse.
Okay.
But how in the world do perpetrators have access to these children?
Yeah, that seems like it just feels like everybody.
It's called a process called grooming. Netflix has done a great job getting documentaries out about grooming. The Keepers, for example, comes to mind. Groomers take time to gain victims and, most importantly, families' trust. They can take weeks, months, even years to gain the trust of a parent. And once they're in the door and the family trusts them as a person who can be a surrogate parent, say in a single parent household, or such as a coach or a clergyman, a neighbor, maybe it's the stepdad, once they gain the family's trust, they have access to the child. In terms of how they do this to victims, they mix normal and abnormal behavior to confuse victims. They teach secretive behavior and make threats to keep victims from reporting. So,
Yeah.
nauseating.
Yeah, that's a lot. Okay, so we're at work, we're in the ER. Tell me how I approach a case like this. It seems a little overwhelming before I even hit the door. I got to tell you, when I started at Children's and learned that the APP team was the primary, kind of group that takes care of these cases, I had to think twice about that.
Yes, me too.
Yeah. But we do this enough that we can get relatively comfortable. But if you don't do this on a daily basis, if this is something you see once every few years, this can feel very overwhelming. So where do we start?
No, and I'll take a brief segue before presenting the most common case presentation that we see. Let's just momentarily mention secondary trauma syndrome. Sex abuse is the stuff of secondary trauma syndrome. And so if you are interviewing, examining, talking to families about child sex abuse, and you go home and find yourself struggling, you are effectively suffering from secondary trauma syndrome. And it is critical that you take care of yourself so that you can come back tomorrow and take care of another victim. So with that said, the most common presentation of child sex abuse is the classic Sunday afternoon family. A 4 or 5-year-old child comes in with a parent after a parent swap because parents are separated or divorced. The child comes home and refuses to get into the bathtub and says, "My vagina hurts." And the parent then looks at the vagina and sees a red vagina and starts to get worried. So they come to the ER on Sunday evening and say, "Can you look at my child and tell me if she have been sexually abused?"
Yeah, we've seen this over and over again.
Sunday, and all other days too, but Sunday is the most common day. So it takes skill and patience and grit to gently take a look at a child's anatomy. And what you will find in child sex abuse is that 95% of exams are normal. If you don't know how to retract a labia to look and describe a hymen, it's important skill. If you aren't comfortable doing that, it would be great to learn. If you aren't in a position to be able to learn, then at that point, you need to find a place that is comfortable. Send them to the local children's emergency department, arrange for an examination at the Children's Advocacy Center, or find someone else in your practice who's comfortable retracting the labia to look at the hymen, or also to look at a bottom if it's a boy. Red vaginas, I will say, do not constitute child abuse, which would be the most common concern. So we also have to be in the medicine of reassurance to tell parents that red vaginas do not mean that a child has been abused. What it also means is that because 95% of exams are normal, the history is the most critical part of the event at the ER or in the clinic.
So what suggestions do you have for us on taking a history? What questions do we ask? How do we start to approach this?
Well, first of all, if the child is over 3 and intellectually spot on developmentally, they can tell their own story. I separate parents from children for a more honest discussion. And this does a couple of things. One, kids do not like to see their parents cry, and they will shut down and not tell their story if they think it's going to hurt their parents.
Mm-hmm, mm-hmm.
2, this is generational abuse, and parents are often victims. And since 40% of victims do not disclose their sex abuse until they are adults, many parents disclose their abuse for the first time to you when the parent brings the child to see you. And it's a good opportunity to get the entire family the trauma counseling that they need so that you can stop the cycle of abuse in that particular family. So if a parent has a chance to voice their concerns, that is great, but it also gives the child a chance to tell you the story in their own words without their parent in the corner coaching them.
So how do you start that? Like, they come in the room together and we're going to go in the room to talk. I know I kind of have my way, but I'm curious what you do. Do you immediately separate them? How do you start?
I explain how the process is going to go from the beginning. One is I warn them in advance. It is very likely that the exam is going to be normal. And just to reiterate that, I always like to have a discussion about what normal anatomy looks like. And I will even have a parent look at the anatomy with me while I'm examining the child. Most people are not taught in school or otherwise that the hymen looks like a donut, that 100% of girls are born with hymen tissue, and it actually looks like a donut. It is not a cherry. There is nothing to burst. And so there is no way anybody can look at a child's exam and say this person has or has not been penetrated. There are areas that hymens can be injured, and you can see an injury, but you don't describe it as this hymen has been ruptured because that doesn't happen. So back to the question answering, I will, after I have explained that the exam is not likely to yield great information in a case, I tell the parents that I would like to speak to the parent, and then I would like to speak to the child. And then based on the history provided by both, I can proceed. Because I am a stranger to the child, it's a very good idea to be gentle and kind and get low at the child's level. Sometimes I'll color a picture with a child in case the child wants to maybe draw what happened or use the pencil and paper as a way to express emotion. They always say ask open-ended questions, but what does that really mean?
Yeah.
I usually start by saying, do you know why you're at the hospital today? Why did your parent bring you here today? And sometimes they will tell you the whole story, and sometimes they will shrug their shoulders and start to shut down. So because illness and injury are the two most common reasons to come to an ER, I ask them if they feel sick or if they have any pain. And if they have any pain, can they point or tell me which part hurts? And then sometimes I can get in that way.
That's great starting advice.
It's critical, too, to understand what, at that child's age, they are capable of explaining. Under the age of 7, cannot date an injury. They can't tell you that on September 20th, Uncle Joe fondled them. They can tell you that Uncle Joe started fondling them when they were 6. They can tell you if it's happened 1 time, 2 times, or lots and lots of times. They can sometimes tell you it happened before or after Christmas because that's a big holiday, or around their birthday weekend. They can tell you it happened at grandma's house in what bedroom. But you have to be careful about the way you ask it because they may not have any idea what you're asking based on the age. And very often these kids aren't 7 yet, so they cannot date injuries. Sometimes the interview takes a long time because the child really has a lot to say, and other times they completely shut down and I have to utilize the information given to me by the parent to decide how to proceed. I only get enough information to know what I need to do for my next step. When we get to the safety plan section of this talk, I will talk about the forensic interview. I do not want to sabotage that interview, so I only interview the child so far as I need to know, do I need to collect evidence? What do I need to examine? And how can I make sure that this child leaves healthier than when they came?
So we don't need to approach this exam like I'm the judge that has to collect every bit of information. Really, we just need to, can they tell me what happened? Establish if this was some kind of sexual abuse, and then document what they said to us in our notes. We don't have to delve into every little detail of this. Is that
correct?
Okay.
Sometimes there is no real history and there are no exam findings, but the behavior of the child can drive an investigation. For example, I would call them green light, yellow light, red light behaviors. Green light behaviors would include little kids touching themselves, which is a completely healthy behavior. Yellow light would be a child trying to touch another child in a sort of maybe questionable way. Red light behavior would be when the child is doing sex acts on a pet, or maybe Barbie is trying to do sex acts on Buzz Lightyear. That is not acceptable. That is high risk for sexual abuse. And so even if there's no alleging of child sex abuse on this child, the child's behavior is telling you that there may be sex abuse going on. That's enough to launch an investigation. Regression of toileting happens commonly, but regression of toileting in the context of a child who was talking in full sentences now seems withdrawn, is wetting themselves during the day and at night, who is also maybe acting sexually around the house, I would put all of that together as a very high risk for sex abuse, even if there's no direct history that someone has actually done something to them.
Yeah. So I feel like we see that in the ER a lot, where a parent brings their kid in and they're like, I found her masturbating in her bed last night.
Right.
Do I need to be concerned about sexual abuse? I think maybe my ex-husband did something.
Yes.
That, with no other red flags, we can reassure the parent
Right.
that's normal.
If, ex-husband is addicted to child pornography, suddenly that behavior becomes riskier. If there's untreated mental illness, substance abuse in a person who was abused multiple times as a child, I at least want a little bit more information, right? I'm not just going to close the door on that. But it's important to kind of ask, what is the family history of child sex abuse? What is the stability of the family? And what other things might be going on that the parent is concerned about? Again, parents so often in these cases were often victims, and they live their lives terrified that the same trauma will happen to their own children.
Mm-hmm.
And so they look to everything the child does as a possible indication that the child's been abused at daycare, which is highly unlikely from a sexual standpoint, or, just in the yard, even though they didn't see anybody.
So on a patient like this, are there any labs or imaging that we need to consider?
Less is usually more. It's never a bad idea to check a urine, certainly in a child who's pubertal age, checking a urine pregnancy test. Unless you have alleged ongoing child sex abuse, which is usually a family member in or near the home, I don't usually do sexually transmitted infection screening. If it is a one-time situation, certainly if it's child on child, I don't usually do it. Again, you're never wrong to check a urine and a urine culture, but usually the exam and the history are going to be what you need the most.
Imaging?
No, unless your exam shows that there may be a deeper injury, such as bleeding from a hymenal os, and you can't see the origin. Same thing for a rectum. Those even don't usually get imaged. They usually go for an exam under anesthesia in the operating room for a better look. And in lieu of imaging, a visual inspection under anesthesia is usually a better way to go.
Yeah. All right. We talked a little bit about the physical exam, but I know you wanted to talk a little bit about when we do and don't need to do a rape kit collection.
Yes. So part of our history is going to be the timing of the event. Who has rape kit collection or evidence collection? Someone who has been exposed to the perpetrator within the last 72 hours, who has had exchange of DNA. So if there is fondling only, there is no exchange of DNA. But if there is kissing, licking, blood exchange, semen, that kind of thing on any part of the body, not just the genitalia, evidence needs to be collected. It's important to talk to a police officer, or even better, a detective, about collecting evidence before you do it, because effectively you re-victimize the victim to go down there and collect swabs and have them expose themselves to yet another stranger or person who is going to do potentially uncomfortable things. So it's good to have the police involved to make sure they actually want the evidence. It's good to have good evidence that there will be evidence to collect before you put a patient and a family through the evidence collection.
Yeah. In these cases, what is our role with reporting to the police and DCS? And we kind of started talking about that, but who do we call?
So yes, a good reminder that all medical caregivers of any kind are mandated reporters of child abuse of all kinds, not just sex abuse. The first report that needs to be made is to your state's intake hotline number. For some states like Alabama, you call the local jurisdiction, the police office. But for most states, they have a centralized tracking system, which is great because it tracks the effectiveness of the tracking system, and it tracks cases that didn't get followed up on appropriately, how long it took them to get followed up on. So we report to the Georgia Child Abuse Hotline or the Tennessee Department of Child Abuse Hotline. And then from that hotline, they determine if it rises to the level of concern and needs to be farmed out to the local county DCS, DHR, DFACS office. So what we are effectively doing is forming what we call a child protection team. We are the medical leg of that team. DCS are the social workers and the safety planners in the arrangement of all follow-up care. The third leg of the CPT or child protection team is the police. They are the investigative unit. They are the ones who take our evidence kit collected and process it at the state lab. And they are the ones who go around and investigate, make arrests, and make charges depending on how severe the abuse is. So we effectively form a CPT in the ER or the clinic and allow the other legs of that protection team work their jobs according to their protocols.
Okay, so we're seeing a sexual abuse case in the ER. We're definitely calling DCS, and we're definitely going to call some sort of police depending on the location of where this occurred. Is that how we decided to call?
That is correct.
Okay.
You use the jurisdiction according to where the abuse takes place. Now, there are complications. We live right on the state line of Georgia, Alabama, and Tennessee. And some states will investigate where the child lives. Other states will investigate where the abuse takes place. And so you could potentially have a situation where neither state will own the case because the child doesn't live in our state or the abuse didn't happen in our state. And so I report to both states in that case, and I explain to them that I understand your laws and I understand that you are following your laws, but if you do that, and if the other state does that, this child will not receive an investigation. And I think we can all agree that would be a mistake.
Okay. And is it true? My understanding is that if we're going to collect a rape kit, we have to know on the front end that the police want it because they have to request it to process it.
Right.
So there's no reason to even think about collecting a rape kit unless you, A, know they need it, and B, the police want it, right?
That's correct. Although the people taking the report initially are usually the younger officers with less experience. You are not usually discussing your concerns initially with a detective. And so keep in mind that just like in medicine, we all have different levels of expertise with child sex abuse. The police also have very different levels of expertise regarding child sex abuse. And the police officer who's taking the report may not know the guidelines for rape kit collection. They may not know that the officer has 7 days to pick up a kit. They may not know a lot of things regarding child sex abuse, and even just being overwhelmed, it might lead them to not necessarily follow the guidelines of their department.
Okay. Is it smart for us to ask, like, who are you?
Yes.
What do you do? Okay. Is
the detective being assigned to the case? I'd
Okay.
like to follow up later.
Yes.
Make friends with your local children's advocacy center, your local detectives, your local social work teams. Make friends so you can best advocate for each child.
Okay. How do you discuss this with a parent? Kind of letting them know I'm involving DCS, I'm involving the police. How do you kind of set that up for success when you have to kind of introduce these ideas of calling all these different agencies?
Well, fortunately for this one type of abuse, the child is usually brought to the ER with the chief complaint of sex abuse. This isn't something we find on incident like we do physical injuries. So the parent is already asking for help, and they are super grateful if you can give them that help. However, once you tell them that you're a mandated reporter and have to involve DCS and the police, there are parents who get nervous. What happens when my ex-husband finds out? Well, what happens when I tell this person who lives in my home they're going to have to leave? It's a setup for a lot of family trauma, a lot of family drama, a lot of arguments, and uncomfortable conversations. And sometimes parents show hesitation about the process. It's important to remember and to tell parents that the number one goal we have here is child health and safety. We want to keep kids safe. That is our job. And the only way to do that is to follow the process the same every time. I like to use the example of working up a febrile neonate. Our newest standards are for term babies to do a spinal tap and a full septic workup on every baby under the age of 21 days. I have personally done about 200 spinal taps on babies, mostly in that age range. I have never had a positive spinal tap. I have never diagnosed a case of viral or bacterial meningitis. But you know what I'm going to do the next time a 14-day-old comes in with a 100.5 temperature?
Spinal
I
tap.
will do a spinal tap because that is the guideline, that is the standard of care, and I do not want to miss meningitis. In this case, I'm going to do the same thing for child sex abuse every time the victim comes in. Once I establish that we have very high-risk circumstances going on, I will involve the police and I will involve DCS. I hope at the end of the investigation, it is determined that the child was not abused. But until the facts point otherwise, I believe all victims who allege child sex abuse, and I believe all high-risk activity that parents disclose, and I think all cases have to be investigated in the same thoughtful manner before determining what really happened. And once I explain to parents that I am doing the same for every child for the purpose of keeping all children safe, most of them abide by the request to proceed with the exam, the evidence collection, all of the follow-up care that is about to ensue.
Yeah, great advice, great advice. And I try to remind parents that I'm not the investigator either. My role here is purely medical and making sure the child is medically okay and safety-wise, they're safe. And it's not really my job to be judge and jury. I don't know what happened, and it's not really my job to figure out what happened. That's up to the officer that's going to be involved in this case. And a lot of times they'll simmer down if you can just reassure them that we're not here to grill anybody. We're just here to take care of your child.
Right. And it's not our job to say who did it, what is going to happen to that person. None of that is our job. It's one of my favorite parts about working in a hospital is that I don't have to make that decision. My goal is to create trust among a family so that if this happens again to another child in the family or to this child again, they can remember that they had a positive response, that somebody really cared about their child and tried to help them, and they will come back to see us. I don't want to close any doors for that family.
Yeah. So how do we disposition these patients? We've seen them, we did the exam, we did or didn't collect a rape kit, we've reported to all the agencies. How does this end? Does the patient get admitted? Do they go home? What's the next step?
Most of these kids do not have medical injuries that require hospital admission. They are extraordinarily rare. So the number one criteria to allow a parent to take a child home is that the parent has to be protective. And what that means is the parent agrees not to allow the child any exposure to the perpetrator while the investigation takes place. And that is easy for some families, but it is not easy for others. For example, if the perpetrator lives in the home, or if there's a custody arrangement that is legally binding and the parent is required to take the child back to the alleged perpetrator's home at 8 o'clock tomorrow morning. The parent can't go against the legally binding custody agreement, but they also don't want to put their child at risk. So it makes it very difficult to safety plan a child from the ER. Sometimes, and I think it's really a great idea for every case of child abuse to screen for domestic violence in the home. If the mother or the father or any of the caregivers are victims of of domestic violence, they may be acutely processing their own trauma. They may also be living in fear, and they may not make a decision in the best interests of the child for the purpose of their own survival. In that case, we legally can bring a child into the hospital and ask DCS to come out and safety plan the child from the hospital. And that way we can ensure that home inspections are done, that parent drug testing is done. DCS also has access to a TBI database for previous DCS involvement of these families.
Mm.
And so they can look cases up and say, you know what, we've seen this family previously 3 times. They've lost custody of 2 children, or I know this family well. They're struggling, but I think I can work something out. I'll go out to the house in the morning. I already know where they live. They have access to a lot more information than we do. So involving DCS early, we call it a P1 or a priority 1 response when we ask DCS to come to the hospital to help with safety plan, is sometimes a card we have to play. If we feel that the parent is not protective or is unable because of housing insecurity or lack of resources, or lack of extended safe family places to go, we can admit the child.
Yeah, and I think just to make it super simple, if that parent at the time of discharge cannot appropriately safety plan for that custody reason or for whatever other reason, they can't leave, right? They have to stay in the hospital. They have to be able to leave with an appropriately protective parent who can provide appropriate safety planning. And if they don't, they're going to stay in the hospital.
Correct.
And we document those exact words in all of our plans so that it's really clear that we've thought through those things before we send somebody home. Here in Hamilton County, we have the CAC, the Child Advocacy Center. If we send this kid home, everybody agrees they can go home with mom. They're safe in the house. What are the next steps?
Right. So one of the things I do ask parents to do, which is difficult, is not to question the child any further about what's happened. If the child wants to talk, be a supportive listener. Thank you for telling me. You were so brave. I'm so proud of you for talking about this really hard thing. But please do not interview your children about what happened, for the reason that they've already had to talk about it at the hospital to a stranger. Now the parent is asking more questions. The child's thought is, well, they must not have liked the answer I gave the first time. Maybe I'll tweak it, change it, or not give the same answer because I would love to not have to talk about this anymore. And ultimately, the most important interview that will take place for this child's investigation happens at the Children's Advocacy Center and is done by a professionally trained interviewer called a forensic interviewer. It's a child-friendly room where the interviewer records a conversation with the child about what happened. That is the interview that holds up in a court of law.
Okay. Have you ever seen one of those interviews?
A video of one, yes, but not live.
Okay. Yeah. Are they? I'm just curious. I've always wanted to see one because I'm curious how that works.
So when I took the PSANE course about 10 years ago, we watched videos of forensic interviewers interviewing children. And it's great to give you ideas on how to approach children, especially children who have shut down and don't want to talk.
Mm-hmm.
It's a great idea to do if you have access.
Yeah. I wanted to talk about at least one case. You were saying that a lot of times these exams are normal, but occasionally we have kids come in with other complaints, and then we kind of stumble upon potential sexual abuse. I worked up a case like this pretty recently on a little girl that came in with dysuria. Her family had actually had some antibiotics in the cabinet and had started treating her, and her symptoms weren't getting better. And on the day she came to the ER, she really was having trouble peeing at all because she was having so much pain. I can't say that I routinely do a GU exam on every little girl that comes to the hospital with the complaint of dysuria. Particularly this one was older. She was like 10 or 11. But I did on this one because she just had described such extreme pain. It just seemed like maybe there was something else going on. And when we did the exam, it was very clear that all of her labia were covered in herpetic lesions. So that, of course, changed the direction of my case. Do you have any cases like that?
I would say herpes is the most common physical finding that you will see in sex abuse because hymenal injuries are so uncommon in kids. And to that effect, anal injuries as well. Lesions are going to be the most common finding. We do, I think, a more thorough exam in the ER because we have a little bit more time. We're not strapped to a 10-minute clinic exam time that a lot of clinics are trying to abide by, so we can look. It probably is important if somebody has a GU complaint, such as pain with urination, just to take a quick look-see.
Yeah.
You don't necessarily have to retract the labia in every patient with dysuria, but just a general look-see at the labia majora in that area to make sure you're not missing an obvious rash of concern.
Yeah.
Because, yes, I'm looking back, I think every case of herpes in a child that I've seen, genital herpes that is, they have been seen by us or another clinic at least once before someone takes a look at the genitalia.
Yeah, I might have to change my practice in that regard. I had another kid that came in I think he was there for a cold, and his grandmother brought him, and ultimately she described that he got these recurrent things around his bottom, and he had syphilitic lesions. So I didn't know that at the time, but yeah, definitely not normal. So yeah, we get these other cases that may or may not be brought in, but always a good idea to do a good exam and be thoughtful in your collection of your history so you can get to the right resources and safety plan your kid.
Yes. I would say if I could say one more critical part of the follow-up while they are waiting for the investigation to take place is to involve your pediatrician in follow-up. Very often, these investigations are traumatic for patients and for families. It is very important for your medical home, your pediatrician, your family doctor to be involved in your care because there are often behavioral changes, trouble with school, more physical complaints, any number of mental health disorders that evolve after child sex abuse. And if you have a trusted relationship with a local clinic, they can kind of help you navigate those in the context of post-child sex abuse care. Before I let these kids go home, I like to reference 2 rules for safety going forward, which is tough because I have effectively violated one of those. Rule number 1 is I tell patients not to play with their clothes off. If somebody asks them to take clothes off at home or somewhere else, that you were told that rule number 1 is always play with your clothes on. And only at a doctor's office or a hospital with a trusted parent at the bedside should that ever be violated. Rule number 2 would be we can no longer keep secrets in this family. We can have surprises because the date of the surprise is known. We're going to get this gift for daddy on his birthday as a surprise, but on his birthday, he gets to know what the surprise is. Secrets have no end, and that is how groomers perpetuate the cycle of sex abuse. And so in this family, now that we've established that child sex abuse is happening, we can no longer keep secrets in this family. And if someone does ask you to keep a secret, you have a trusted adult that you can go tell who will hopefully keep you safe from that secret.
Okay. You tell that to the kid. That's awesome. Yeah.
In front of the parent. And very often, if the parent has not already disclosed a prior history of abuse, the mom will cry and say, I wish someone had told me those rules when I was 7, 8, 9, 10. They almost always say that.
Yeah, that's great. I haven't done that, and I absolutely will do that. So the other thing we wanted to cover today was sexual assault. So we're going to change gears and talk about this. This is a little different presentation. Tell us about kind of the laws of consent. Now we're in Tennessee, so just keep in mind these are going to look different depending on what state you live in. But we're going to talk a little bit about what consent looks like here.
Okay, for sexual assault in Tennessee, the age of consent for sexual behavior is 18. However, there is a close in age exception that requires 2 consenting partners who are at least 13 years old and less than 4 years apart, which means that a 13 and a 16-year-old can consent to be with each other, but a 13 and an 18-year-old cannot. If the victim falls outside those parameters, a 12-year-old victim, for example, or a victim who is more than 4 years younger than the partner, that constitutes statutory rape. Parents have a very difficult time with this law. They will say, but she said it was okay. This is her boyfriend.
Mm-hmm.
But if it is against the law, no consent can be made. Now, the victim has to be mentally and physically competent, intellectually not disabled. They cannot be under the influence of controlled substances, drugs, including marijuana, alcohol, and they cannot be a nursing home patient. None of those people can consent to sexual behavior. And so if someone is a little buzzed, they are legally considered drunk. They cannot consent to sexual behavior.
Oh, good to know. When we do an H&P on this patient, what tips and tricks do you have here?
It's tough because a lot of victims do not want to tell you the actual age of their girlfriend or boyfriend. They want to protect them because some do actually want to be with that 22-year-old. So that is tough. I think it is good to establish that you are practicing within the scope of your state laws, that you aren't choosing to or to not inquire or investigate sexual assault, that you are basically just following the law. History is still critical because A, you're deciding whether this person needs to have evidence collected, and B, do they need to have any follow-up medical care? For example, if a patient has been in an ongoing situation where sexual assault is happening multiple times, they're more at risk for sexually transmitted infections. It's important to know if there was condom use. It's important to know what parts of the body were involved, because if you are going to be collecting evidence, you need to know where to collect it on the body. In the case of sexual assault, the perpetrators are not caregivers. So this cannot be the patient's coach, uncle, teacher, parent, anybody who is in a caregiver role. In the case of sexual assault, the perpetrator is a non-relative, non-caregiver person. And that changes the way things are investigated. In this case only, not in child sex abuse, the patient has the discretion to decide whether to call the police and whether to have evidence collected.
Oh, but if this was their minister, we're going to have to do that.
Then it is a case of child sex abuse.
And we revert.
And we absolutely involve the police. We involve the child abuse hotline, and we secure all follow-ups as if this is a child sex abuse case, which it is.
Can they still refuse to allow us to collect the kit?
Not on a child, but I will be honest with you. If you are comfortable with your job and you explain the law and you explain why you're doing this, I do not have people refuse evidence in cases of child sex abuse.
Okay.
In cases of sexual assault, I absolutely have people refuse evidence.
Yes.
We have to remember that when victims come to us acutely after sexual assault, they are still in the moment of trauma, and they don't always make great decisions regarding their health and safety. And so we can't be judgmental in this case. In the case of sexual assault, instead of sending kids to the Children's Advocacy Center, we can call the Partnership Rape Crisis Center, and they will see victims up to 120 hours after an assault takes place. So not the same as in child sex abuse, which will only collect evidence up to 72 hours. Rape Crisis Center in Chattanooga will see victims up to 120 hours later. Is there still evidence at hour 119? Probably not. But there's still a great opportunity to advocate for patient, offer counseling, offer legal advocacy, STI screening and treatment, Plan B, etc.
And how old do you have to go to do? You have to be a certain age to do that, right?
Yes. So the Sexual Assault Center in Chattanooga will see people ages 13 and up who are mentally competent, not intellectually disabled, whose perpetrator is not a caregiver.
Okay. I guess that's the part you have to differentiate really well.
Yes.
Yeah.
It can get confusing in the moment.
I've also had them come to the hospital on some occasions.
Sometimes patients aren't clinically cleared to leave our department. Maybe they have to stop vomiting. Maybe they have injuries that need to be treated. Maybe because a lot of these victims come to us suicidal, they need a behavioral health evaluation for possible hospitalization for suicidality. So we cannot send them home or to the sexual assault center from the ER. We have to keep them in the department to stabilize other parts of their trauma. In that case, the adult SANE will come out and collect evidence for us.
Okay. When do I call the police?
Patient discretion, assuming the perpetrator is not a caregiver. So if this is a child who was raped in the high school bathroom by another student, or if this is somebody who went to somebody's house for a party and got raped there, it is up to the patient's discretion as to whether or not to collect evidence.
Is DCS involved?
Only if the parent of the minor is not protective of the child, or if the perpetrator is in a caregiving role.
Okay.
So perpetrators of child sex abuse and perpetrators of sexual assault are very often serial perpetrators. They have more than one victim. And so police really do need to investigate to see if there are any other victims and decide if they can make an arrest or effectively keep other people safe from the perpetrator. And so, but sometimes victims of sexual assault don't want police involvement. And that is difficult.
Yeah, it's hard.
Mm-hmm.
And I find it's normally when, the kid met this boyfriend on Instagram and, he's potentially someone they might care about. And They don't want to get them in trouble. Okay, great advice.
Yeah, it's one crime where victims are placed at fault by society, by their families, by perpetrators. And so victims come to us feeling guilty that they dressed a certain way, that they shouldn't have had 2 beers, that they made this decision and that decision is what got them assaulted. We really, really, really have to change the dialogue and change the responsibility from the victim to the perpetrator. It's the only crime, domestic violence included, which is another form of sexual violence. It's the only crime where people assume that the victim is at fault somehow.
Always. Do we do labs on these patients? Is there any testing I need to do for this patient?
Yes. So in this case, we actually do screening and we offer treatment. First off, we explain what Plan B is, and we offer that as a way to stop a pregnancy from happening as a result of the assault. 2, we offer treatment of sexually transmitted infections. So they can receive Rocephin in the ER. They can also receive prescriptions for doxycycline and Flagyl. And we can discuss post-exposure prophylaxis for HIV with them, what their risks are, whether they should take it, and how that works. We screen for pregnancy at the time of assault. We also can send off sexually transmitted infection screening. Then we also have to set up a follow-up system because if the person is at risk for contracting HIV or hepatitis or a sexually transmitted infection, they need to have follow-up screening at a later date, which won't be done in the ER. If they are altered in any way and we are concerned that they may have been given a drug, we have a date rape profile, which includes Rohypnol, GHB, and ketamine. We also screen them for alcohol intoxication, and we do an extended drug abuse screening to see if they have anything under the influence at the time of presentation.
I'm not sure I knew that we had the extended date rape drug screening. So how do we order that?
It's a send-out test. It's in the sexual assault panel in our ER.
Okay.
And 2 of them...
So it won't come back that day, but...
No, they're send-out tests, but it's great for evidence collection. So you have to use your chain of custody form, send the samples to the lab. It's in the guidelines how to do it, like how to collect the specimens. And then one test, which is Rohypnol, does not come up in Epic. So you have to do it as a downtime order.
Okay.
And it generally takes about 2 weeks to come back.
So if this, I guess if they're over 13 and we've involved the CAC, really, or not the CAC, but the partnership, they're going to really arrange for all this follow-up for this person.
Yes. I think they send their patients to SIMPA for follow-up testing.
If this patient, let's say we collected the rape kit on this patient, we did the labs, we collected all we provided the medicines, the Plan B and the STD protection. What follow-up happens next? Can we still send them to the partnership? How do we arrange for like counseling later and looking out for like their retesting for the STD exposure and pregnancy?
That is a good question. And that again is where the reason that patients need a very good medical home. Usually they will need some kind of a follow-up that won't be done at the partnership if we didn't involve them initially. SIMPA can do the follow-up screening. Primary care offices can do the screening if willing. That can be a challenge for a lot of these adolescents who have maybe lost touch with their pediatrician and don't have a place to follow up. SIMPA is a great option.
Okay. Do you call the pediatrician and let them know, like give them a heads up?
We have new in our department in the last month or so. We have 24-hour social work care. And because there's a tracking system for all of these kids, the social workers call the PCP offices within a couple of days of ER presentation to make sure that the PCP knows that they were seen in the ER for sex abuse, sexual assault, and they inquire about follow-ups.
Okay, that's awesome. Yeah, I'm not even sure I knew they were doing that. That's great.
New.
Okay. All right. Anything else you want to add?
No, thank you for having me. I am fully aware how uncomfortable this conversation is. Here in the hospital, And I am very aware of how difficult it is to process these cases after these kids leave. It begs good health in all providers who care for these kids. Take care of yourselves, have a good support team, have someone to call, have hobbies, have everything that you can to take care of yourself so that you don't wake up at 2 in the morning worried that you did something wrong, worried that anything, worried about yourself, worried about the patient. You don't want to do that because you will wear yourself down rapidly and not be able to provide the same care for the next person who comes in.
Yeah. And if you're in the Chattanooga area and any one of our surrounding hospitals, you can always call us with these cases. We will help you over the phone, how to navigate it. We will take the patient there. We are always happy to see these patients. And then if you're not in our area, you just need to know your resources, know where your local children's hospital is, know where you can call to get some guidance on a case like this. Before I worked at Children's, I certainly phoned a friend at Children's on more than one occasion to get some guidance in this regard.
Absolutely. I think that's one of the first things I learned out of school was to develop a large Rolodex of community support when I didn't know how to do something.
Yes.
Who can I call? And so in this case, it's really, really great to make friends at your local CAC and your local children's hospital, and even your police department to know how to do things so that nothing is left to chance for these kids.
Yeah. Thank you so much for coming today.
Absolutely.
Enjoyed having you. Thank you for talking to us about this tough topic, and I'll see you around. Hey, PemChat listeners, thank you so much for being here today for this chat with Jen Stanfield. It was great to have her on the show today. I have some really exciting news to share with you, and that is our next episode in March. I'm going to be joined by Dr. Beach Gem out of St. Pete, Florida. Most of you probably know her from her social media platforms. She's available on all of them, and she's the Pem next door that we all want to have in our pocket. She's a great resource and a cool person to talk to. And she's going to be joining us to talk about pediatric pneumonia and also some of the interesting phenomenon we've seen all across the country this year with regard to pneumonia. Please join us then for a fun episode with Dr. Beach Gem. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.